Hi everyone, and welcome to the 8th workshop in our series on transforming health services in line with the government priorities. Before we start, I'd like to introduce ourselves. We are Unity Insights, a social enterprise embedded in the NHS, having historically been part of one of the health innovation networks. We have a vast experience of working with healthcare professionals, innovators, and commissioners to support with NHS-specific challenges. I'm sure you're also wondering who we are and our roles at Unity Insights, so I will first pass on to Pete, who will introduce himself.
Good afternoon, everyone. My name is Pete Aldridge. I'm a senior analyst at Unity Insights. I've been part of the company for 6 years now, working across a wide range of clinical areas, stroke, cardiovascular disease and mental health. I've also been involved with a number of the post-pandemic operational changes around the spread of online and virtual consultations and improving booking services. In general, I specialize in quantitative evaluation designs, including things such as systems thinking into our evaluations, but I've also been involved in a lot of qualitative evaluation deliveries as well in my time. Pass back to you, Kate.
Thanks, Pete. My name is Faye Maddock. I'm a senior analyst at Unity Insights. I've been with the team for just over 3 years now, and whilst being part of the team, I've used various analytical techniques in many different projects spanning from evaluating apps aiming to improve operational efficiency to radiotherapy treatments for cancer. Today's focus is on power to the patients. We will go through the challenges related to this topic and how the government and NHS priorities aim to alleviate these issues. We will then highlight how we demonstrate impact with some examples before sharing with you our learnings and key takeaways. We will take any questions in a Q&A session at the end, so please use the Q&A function to ask any questions that you have. I'll now pass on to Pete, who will go over the current challenges faced and the ambition set out by the government.
Yeah, so if we go straight on to the next slide, please, Faye. As you know, probably from the introduction to this workshop, the manifesto has a clear statement at its heart around keeping patients at the heart of healthcare delivery. And in terms of what that practically means, the focus is on treating people with respect, ensuring that patients are able to access support when they need it, ensuring they have the information to be able to navigate the system and also well informed about the care pathways and treatments for their conditions that they may be or symptoms they may be having. And also ultimately empowering patients to make appropriate choices about their care and its delivery along the way. So there's a number of obviously existing sources that highlight things from the perspective of patient experience and satisfaction. And we've collected a few of the key figures here just to try and illustrate the issue at the heart of this. So the first couple are taken from the CQC and relate to urgent and emergency care, with 47% of A&E patients not able to get help with their conditions or symptoms when trying to access it. And even then, if they have received treatment when attending an urgent treatment centre or A&E, they may leave with further questions once discharged and feeling that their concerns haven't been fully answered when they leave. Obviously, there are a few different challenges wrapped up in this, not just the services themselves, but whether the patients are going to the appropriate services to receive care. But that kind of has the challenges around the ability to navigate the system or having the right information to hand. They're kind of embedded in those issues and create the problem of people going to an inappropriate location. Further to this, Lord Darzi released a letter to the government regarding an overview of clinical services in the country. And within that, he highlighted some of those issues which affect patient satisfaction have led to rising complaints across the NHS and a rising compensation bill for care failings as well, which is currently equivalent to around 1.7% of the whole NHS budget, which is obviously quite significant. Across primary care, if we go to the next slide, please, Faye, thank you. There are similar trends as well. So since 2009, in fact, satisfaction's generally been declining within primary care as collected through the GP patient survey. there was an acceleration around COVID, as people are probably aware, but it has been a longer term trend than that. Less than half of people find it easy to get in contact with their GP over the phone, and a lot of the new alternatives that have been introduced in recent years through the app or through practice websites are actually rated lower in terms of the ease of use compared to going through the phone. And then when people do get through, they're not always offered a choice of the time or day for their appointments, 41% as indicated on there. And around a third of people feel that it takes too long to get an appointment anyway. Within that as well, there are further details captured through the survey and in other sources which show that obviously in this day and age, people who feel that it takes too long to get an appointment will try to self-serve, and they'll go online and they'll try to find answers. They'll look up their symptoms online and find who knows what information about what it could be and what they should do to try and improve their health. So there's quite wide-ranging challenges that exist in delivering this upon the manifesto. A lot of these involve incorporating the right pathways for information, communicating effectively to patients, and providing options and choices and empowering the patient along the way. The results in terms of staff across primary care are really positive within the patient survey, and I've highlighted that. They're massively positive. And so it shows that the willingness and the help and the information all exists, the skill base is there. It is largely an issue of access that creates satisfaction challenges in this area. So if we go on in terms of what the plan is to address some of these challenges, you can see them, that's good. So obviously, as I've mentioned already, keeping the patients and their families at the heart of medical decisions is a really key priority within the government's pledges. And I've mentioned already the importance of keeping people informed and creating systems and pathways that are easily navigable for patients and their families as well. The development of services that can help, that are receptive and can help and relate to the patient's perspective are obviously essential to this as well. And the government, if we move on, are undertaking a few actions to lay infrastructure that can go across the NHS to help support in this way. Key to that is obviously the development of the NHS app, and also the establishment of a range of patient standards that will cover the entirety of the NHS. And they've been detailed in the Plan for Change, which was recently published. A lot of them do relate to things such as the ability to view, manage, and book appointments directly, to provide choice in terms of the number of providers, and allow people to book and review the results of diagnostic tests and other checks along the way, hopefully reducing some of the demand on services in terms of the need for follow-ups, allowing patients to select whether and when and where they need those follow-ups. And also choosing from a range of providers across different settings. It's not purely designed around patient experience, though. There are other impacts and benefits that are intended to happen along the way. The intention that improving some of these booking processes and appointment management processes will reduce things such as missed appointments, with 8 million, I think, in the last year, elective care appointments missed, highlighting that creating the space for people to pick an appropriate time and place should hopefully result in fewer DNAs along the way, and which will obviously release time and reduce pressure upon clinical services. So as an evaluator, we're obviously been thinking about this as well, hence the workshop. A key part of our process to understand who engages with interventions and changes as they're being delivered, and also making sure that we fully understand the barriers that affect delivery. If you could push the slide on, thanks. A key part of that is developing a qualitative approach that goes alongside any broader quantitative delivery type evaluation as well. So quantitative data obviously really helpful to understand that things are in place, that they work, that they're up to speed, and what works and what doesn't, which functions are being most used, these types of elements. But qualitative really helps you delve a lot deeper into the factors behind why something works, and also understanding who it works for and highlighting things such as potential health inequalities along the way. Key to that, hence this, is from the very conception of a new project or intervention, considering public and patient involvement and engagement. And that can be, or PPIE, which can be anything as much as gathering information about what the needs are of the patients, or it might be a fuller program of co-design along the way. And we'll go through some examples shortly. Before that, though, some of the key approaches that are taken with this and some of the options available which suit different needs along the way. Most obviously surveys, which everyone will probably be familiar with, very replicable and easy to get a broad consensus across a larger audience. Can easily be repeated at different points in time as well, so you can observe trends and whether one set of answers has been addressed if they highlighted a certain issue within the service. The other two options are there really, and rather than providing that breadth and overview, they provide the opportunity to go in depth for certain things. Our preference in general was to conduct semi-structured interviews as part of our evaluations. They allow us to set themes and plan questions, but while leaving some space that allows us to delve into barriers, points of conflict against the initial intentions of a project, and also explore true stories of success as well, which can be equally helpful in providing insights into what works, what doesn't, as I said, who for. And it gives you a lot more detail, obviously, around body language and tone and things like that along the way. Focus groups as well can be enormously helpful to yield very in-depth perspectives from a specific perspective or stakeholder cohort. So whether that would be patients or staff or carers or whoever it might be, getting people around the table speaking about their experiences and seeing that spark off thoughts and ideas, or again, contrasting experiences along the way, can be very useful to help identify some of the barriers and some of the variation that exists in services, which is a really, really helpful part for any PDSA cycles that different projects will be going through. There are other options as well, but those are the core main three. So in delivering them, obviously all three of those require some element of listening to the patient groups. And we're going to go through a few examples in terms of projects that we've undertaken that have sought to amplify the patient voice as part of the government's plans, in which Lord Darcy is highlighted here as well. And in the aim of increasing access and creating services that are more responsive to the needs of the patients and flexible to the individual needs of patients as well. We've got a number of examples here of different pieces of analysis and evaluation work that we've been involved in. One of the key areas, and the first two examples relate to this, is in relation to mental health, which post-pandemic in particular has been an area which has faced enormous pressure and rising demand across the population. So there's been long-standing concerns in here relating to access, and in 2023 we worked with Surrey and Borders Partnership as they delivered their community mental health transformation, and one of the key points that it was trying to address was meeting pockets of unmet need within the community by creating a more open access and flexible culture within their services. They launched around 10 different service lines as part of this transformation, and the intention being that a lot more of these were geared around providing support to people as they are, rather than requiring things like formal diagnoses or certain markers to be met that meant that a service would be appropriate for them, because that's been one of the major issues around mental health, the need to fit a certain clinical profile before you can access support. And if patients are being referred prematurely to certain services, they'd often be sent back to primary care or back to another service, and it creates this bounce, obviously a very poor experience from the patient's perspective. At the core of the mental health transformation, the service called GPIMS was put in place, which included skilled mental health caseworkers who would work with the individual involved to understand their needs, and then almost take a multidisciplinary approach to care planning from that point. So bringing all the other organisations, third sector, other service models into the room to discuss what's the most appropriate course of action to support this person and their needs. And some of them will be saying, well, they're not quite at the point where that we would be able to provide direct support, but we can suggest A, B, or C other alternatives, and providing just like a single point, a single clear answer, clear information of what the landscape looks like for that individual that can help them provide access, even practical support along the way. And once they're into the service, it established self-referral routes. They could always come back straight in at the GPIM stage, be bridged into other services they may need. And this is all part of a service design that took people with lived experience right at the center of the project, from design right through to delivery. And I've highlighted as well the Home First service, which was a slight outlier in a sense of a need that was identified for people who are high intensity users of healthcare services, with multiple regular stays in hospital, for instance. And again, taking a very similar approach of dedicated caseworkers, multidisciplinary approaches, and promoting the voices of people with lived experience, being able to provide the right support and advocacy along the way to hopefully reduce some of those stays and provide a sense of stability for the people involved, rather than always being bounced across between different teams. And with our next example, which is quite similar in some respects, advocacy and lived experience are at the heart of the service model again. We're working currently with Dorset Mental Health Forum to help develop their measurement and evaluation plans covering the next 5-year period. Again, they offer a huge range of services with a large focus on recovery education and informing and building understanding across the community at all levels in terms of understanding the impact of trauma on people's lives. So again, not setting things around diagnostic benchmarks, but creating a culture of providing the right intervention at the right time to avoid the need, or the perceived need of, I need to be worse before I can get help, which is obviously a huge issue, closing doors rather than opening access. A key part again of their service plan is around advocacy as well, and providing regular contacts, known trusted individuals who can support vulnerable people when they are accessing psychological or clinical services, which yields positive benefits both to the clinical service itself as well as the individuals involved. A large part of our work around this has been developing theories of change, logic modeling different projects, and developing the systems to understand what impacts are expected or what outcomes are expected and who the beneficiaries are for those outcomes. And then that will then inform the measurement plans going forward, so the right data is being collected to understand, are the patients really yielding the benefits of these services? Are they going elsewhere? Are they going into the system? Are there social benefits that we would have otherwise have missed? And it's a process when it comes to demonstrating impact of change, which, just like planning qualitative evaluation approaches, is really key, and it's a major part of what we do in supporting people in that benefit identification process. Moving away from mental health examples with our next one, in 22 and early 2023, we worked with Health Innovation West of England, or West of England AHSN as they were at that time, to evaluate the Black Maternities Matters programme, which was run in Bristol. This is a training programme aiming to inform and educate maternity staff about some of the factors that have resulted in health inequalities in the pregnancy time and postnatal period. There are significant disparities in this area. I think that the Embrace report, which was released in 2019, found that Black women are more than 4 times a lot more likely to die during pregnancy than white women, and stillbirth rates would double that of white babies as well. So there's significant health inequalities in this area. And the approach with this was, again, promoting the voice of people with lived experience and delivering a program, I think it was 6 or 8 weeks program of anti-racist training for staff, so they can hear the experiences of people affected by the programs. There were concerns about it, and one of the reasons and things that we had to explore through the evaluation were concerns of it's a very direct model of engaging with some pretty uncomfortable subject matter. but the feedback around it was hugely positive. And at the end of it, each of the trusts involved had champions on the teams helping drive practical changes off the back of the training. The feedback, as I've said, was really positive. Some of the elements that came out of our surveys and focus groups around this highlighted a bit of a Dunning-Kruger effect, which is where people would overestimate their understanding of something before they heard the direct feedback, which is something that could well exist in other areas across healthcare, obviously. So a huge factor, and the kind of approach, with even being, I guess, not shying away from the difficult areas of discussion, yielding results for the maternity teams there. And that project has continued since then with a wider range of changes and delivery off the back of this initial stage. So to summarize these last few points, obviously these are a few examples. We've got a couple more here as well, which I'll run through in a second quite briefly. A range of different areas, and one of the things that we come across quite a lot is putting the patient at the center of delivery and designing evaluations to make sure that we're measuring these things. Quite often budget management and things like that can take precedent of certain evaluation designs, but understanding what works, for who it's working in, and why is obviously a key part of that journey as well. So understanding stakeholders, developing theories of change, involving including PPIE in the design of projects from co-production right through to the evaluation stage, and using qualitative methods to help get in-depth insights into what's working, why. So a couple of other examples that we used, we engaged with people with, well, a few services that were there for social engagement with people with learning disabilities and raising education and understanding of the rights for reasonable adjustments to be made, and increasing the uptake of adjustments, and obviously making people off the back of that more comfortable to engage with healthcare for vulnerable groups who are more at higher risk of certain conditions and things arising. Another one is an example of Shooting Stars Hospice at Ashford and St. Peter's Trust, where the embedding of a support worker actually within the neonatal ICU to provide to build relationships with families who are having their babies admitted to intensive care, creating connections, helping support them in undertaking positive actions in the meantime, or where obviously a period of enormous stress for the individuals. It was a quite direct and straightforward change to a process, replacing what we always call signposting, and obviously having a real person there to build that trust and relationship as opposed to a leaflet is enormously more beneficial from the perspective of the families, but also released a lot of pressure on staff who felt they had to make up the shortfalls at times and increase their time then that they had available to make sure they're delivering the best care to other babies on the unit. So a couple more really good examples there of incorporating the patient voice to deliver change. Now I'm going to pass back to Faye, and it's going to talk about some of the information-informed patient decision-making examples.
Thank you, Pete. So first of all, let's go over patient choice and why we want to allow patients to have this choice. Why is this beneficial? Patient choice empowers patients through autonomy. Patients can gain control and make decisions on their health that align with their personal values, priorities, and lifestyle choices. When patients are more involved in their healthcare decisions, they tend to retain more information, and this helps them be able to ask questions and be better informed about their condition and the care that they require. In turn, this builds a solid foundation for making the correct decisions for themselves early on in their care, which can then help with their future care. As patients understand their condition and the options available to them, they're more likely to be able to have open communication and have meaningful conversations with healthcare staff. This ensures that patients are aware of the risks, benefits, and outcomes of each care option available. Having open communication also builds trust between the patient and healthcare staff, allowing confidence in that the patient is making the correct decision for their unique needs. This is more likely to lead to greater satisfaction with their healthcare choices. Currently, tools are being developed to put patients in better control of their care. One way that this is being done is through allowing control of appointments. Self-Book by AccuRx supports GP practices to schedule and book appointments online, addressing growing primary care pressures and declining patient satisfaction with GP practice access. Self-Book offers a choice of time slots that were suitable for a GP practice and then allowed patients to select an appropriate time slot from this list for their appointment. Partnering with Prova Health, we conducted an independent evaluation of Self-Book, where surveys were used to understand the patient perception. Survey results showed that patients had a positive experience of using Self-Book through offering a contemporary way of accessing services for patients. Here, most patients found Self-Book easy to use and would recommend it to others. In turn, use of Self-Book allowed for increased patient decision-making, increased patient empowerment, and reduced time pressures for the GP practice. In our evaluation, we also completed some health economic modelling findings, which are as follows. And these findings suggest that Self-Book is likely to provide substantial benefits to primary care organisations once it's an established part of the operating process. In terms of our impact then, so through qualitative and health economic analysis, we help to highlight the uptake of Self-Book in GP practices. The evidence from the impartial evaluation is intended to support AccuRx in their case for contract extension and wider scale up for the Self-Book solution across the NHS. This highlights the role of evaluation in evidencing how patient choice can have a positive impact on the NHS. Ensuring patients can manage their symptoms and understand their condition yields benefits for both patients and the NHS. Patient self-management involves educating patients about their conditions and treatments, equipping them with the knowledge needed to make informed decisions that align with their personal values and health goals. Both patient self-management and informed decision-making emphasise the patient's active role in their healthcare, fostering collaboration with healthcare providers and ensuring that decisions are well-informed and actionable. By engaging in self-management, patients take responsibility for their health, which enhances their ability to evaluate treatment options and make decisions that support sustainable and effective health outcomes. Apps are commonly used as self-management and knowledge tools. It's essential that patients receive training on these apps where necessary to ensure that the app is being used appropriately and to encourage buy-in and long-term adherence through the app. For example, in an evaluation of a COPD app, we found that champions trained patients on the apps, and that was then found to lead to greater patient understanding of the different functions and exercises to help with their COPD that was within the app. And we might not have actually found that this was the case if patients weren't trained on how to use the app. So it's just highlighting the need for this training as well in this case. Communication must also be sufficient to allow patients to contact practices or discuss their condition or treatment options. This leads to effective communication, ensures they can seek clarification, ask questions, and share concerns. This ongoing dialogue is crucial for informed decision-making, and it ensures that patients feel confident in their choices. In a recent evaluation, we identified that although shared decision-making was high within a GP practice, patients were actually struggling to contact their GP practice. And that highlights the importance of patients being able to communicate at all points of the system, so from start, treatment, and end. Through conducting qualitative analysis, we identified that this was the case. And this just strengthens the importance of examining communication at different parts of the pathway. Although once part of the pathway, patients experienced great communication, it was actually a different story to get them into the pathway in the first place. And if we didn't examine the ability to contact the GP practice, we would never have known that communication was an issue here. Staff must be able to provide trustworthy context and support in a controlled way to patients, and this ensures that patients have access to accurate and relevant data, enabling them to make well-informed decisions about their health. Currently, there is an emergence of apps that intend to put condition-specific information relevant to the individual user in their hands, and that then leads to informed patient decision-making using trusted sources rather than just Google search, and that provides clarity on conditions and treatment options specific to their needs. So I'm going to wrap up now with some key takeaways from today's workshop. To conclude, we must understand the patient experience to know whether the innovation is working as intended. Just because an innovation may appear that it provides patients with a choice, it doesn't mean that this is actually the case. This emphasises the need to understand what works, and we can do this by conducting evaluations. When we conduct these evaluations, we must respect and listen to patient views and experiences. This can provide vital insights into whether the patient can make the informed decisions that they deserve to. PPIE groups are a great way to include patients as part of a co-design approach, whether that be for an evaluation or implementing an innovation. And this ensures that the innovation considers the patients from creation to implementation and beyond. Finally, it's important to understand the needs of the population, and we can do this through health inequalities and understanding the barriers to accessing care. Conducting evaluations helps us to listen to the patient and understand from their side the levers and the barriers to the success of an innovation. This can provide vital insights, which can then help create recommendations that will improve an innovation for the better. So we really hope that you enjoyed this workshop. As we mentioned earlier, this is the 8th in a series, so I just wanted to show you the full list of subjects that we're covering. If this has piqued your interest, there's also links to the workshop recordings and to our Eventbrite page, which has more details on each workshop, as well as the sign-up instructions.